Hi everyone, I am Alina Isaac. I'm a research fellow in Antimicrobial Stewardship Program at Amala Institute of Medical Science, Thrissur. Today, it is my privilege to moderate this current session about clinical microbiology under ID Forum. So, we are moving to the second cycle of the session, and we have a renowned clinical microbiologist on the board. She's a gold medalist for MD microbiology, and she's none other than Dr. Sadia Khan, who is working as an associate microbiology professor in Amrita Institute of Medical Science, Faridabad. She is a certified infection control professional, and she has more than 10 years of experience and had played a vital role in creating the Kerala state antibiotic policy, which is the first federal antibiotic policy in India. She has proved her excellence in hospital infection control, molecular biology, and has won more than 30 publications to her credit in many peer-reviewed national and international journals. So, without a delay, let me welcome Dr. Sadia Khan. Over to you, ma'am.
Thank you, Alina, for that kind introduction. And as we start this session, I would thank the organizers for giving me this opportunity to discuss a very important topic regarding reporting and interpreting of antibiotic susceptibility testing, which is essential for any diagnostic stewardship or antimicrobial stewardship activities that you will be carrying out in the future. So let us start the session with an Oslerian thought of why should we take antibiotics. So as far as we are concerned, William Osler was the father of modern medicine, and William Osler had a thought process where he discouraged use of any medicine, not only antibiotics. So he used to say that the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. And during the Oslerian times, probably it was easier to practice medicine without antibiotics because there were very few diseases that he actually encouraged treatment with antibiotics or treatment with any medicine for that matter. But today we realize that it is not that simple, especially with the menace of multi-drug resistant antibiotics, which are multi-drug resistant organisms which are there, and also with the kind of complicated clinical treatments that have come in or the complicated surgical procedures where we do require antibiotic cover for anything to work seamlessly. So, as Osler had said, one of the first duties of a physician is to educate the masses not to take medicine. So, almost 100 years after William Osler is there, I think as an antibiotic stewardship team, we have come a full cycle where again it is our duty to ensure that antibiotics are not taken without any indication. It is not that we do not want antibiotics to be used as a blanket ban, but it is rather important that we do rational use of antibiotics. So with this thought, let us go into our session. So in today's session, your antibiotic susceptibility testing report is the hero of our entire session. And in this session, these are the learning objectives that we will be taking care of. We would like to interpret an AST report or an antibiotic susceptibility report, and we'll like to see how to choose an antibiotic using such a report. What are the methods of AST testing? What is MIC? What is its definition? What is its application? How should we interpret an AST? And at the end, we will just browse through certain case scenarios to drive home certain important concepts that you need to understand or you need to clarify while you're working with while you're working in the field with certain antibiotic reports. So this is how we have chalked out the session for today. So as a microbiologist, if you ask me how antibiotic susceptibility reports are generated, I would imagine a picture something like this, So these are various steps of how antibiotics susceptibility testing is done. And it is not a simple process. It is a process which takes many days. And as a microbiologist, I will always wonder how complicated the generation of AST reports is. So hundreds of plates are swabbed, hundreds of antibiotic discs are put, then we measure it with various measuring devices, and finally we come up with very complicated reports. We compare it with certain parameters, and then finally we get a report that we churn out. Now it is also interesting to see how antibiotic susceptibility reports are interpreted. So this is how we generally see the interpretation goes about. So a lot of clinical pharmacists tell me that they were never taught how to read an AST report during their courses. Okay, and even physicians do tell us that we were not taught how to read an AST report. So generally, what we assume is that if it is S, it means sensitive, which means a green signal. Let's go ahead. Or if it is resistant or R, we think that, okay, you stop this antibiotic, you cannot give this antibiotic. So very often I ask them, what do you do if it's an I? So most of them say that we don't know what to do with I. We don't go towards those antibiotics. So with increasing antimicrobial resistance, we don't have the luxury of not understanding how to read an antibiotic susceptibility report. Okay, so how do you choose an antibiotic, right? Having known that, how would you choose an antibiotic? Most of us would say that AST reporting or the report itself will guide us as to which antibiotic should be taken. But it's not as simple as that. The AST report is a very important guide, but along with that, you also have to see several other factors. Okay, the most important being what is the site of your infection. So when you have your AST report, with that, you have to see that whether it's a urinary tract infection, whether your antibiotic that you're choosing would act on a urinary site, whether it's a sepsis, is your antibiotic truly sensitive and would act on the blood site, or is it a pulmonary infection and would your antibiotic that you're choosing would penetrate the lungs and act at that site. So that becomes a very important factor to decide what is the site of your infection. Other than that, toxicity is very important. Certain patients may have renal parameters, they might require adjustment of the doses for renal toxicity. So, in those cases, you have to see whether your antibiotic will stand that test of toxicity in a particular patient. Also, many patients are allergic to certain antibiotics like beta lactams. That obviously cancels out that choice of antibiotic in this particular patient. The cost is again a factor. Some antibiotics for the entire course of administration work out to be very, very expensive for the patient to afford. So, in these cases, you might have to choose a susceptible antibiotic which is cheaper. So these are some of the factors which are required to choose an antibiotic. I am not going into the pharmacological factors or the PKPD and those factors because I'm sure that would be covered in detail in another session, and they are also very important when you are choosing concentration dependent antibiotics. So in this session, let us review how antibiotic susceptibility testing is done. I will be very brief about the susceptibility testing methods because I'm not addressing a group of microbiologists, and this is something that a good lab will do for you. So essentially, there are two methods of AST testing. One is your distribution method, and one is your broad dilution method. There are many others also, but these are the two methods which are essentially done in most of your laboratories. So most of the reports that you will get as practicing clinical pharmacists or as clinicians in the wards or in any OPD or whatever you get from the lab will be based mostly on distribution methodology and broad dilution. So let's come to distribution methods. These are the simplest and the easily available methodology for antibiotic susceptibility testing. The reason that they are so simple is because you do it on an agar plate and you take a manual reading. So the agar media that we usually use is Muller-Hinton agar. The Muller-Hinton agar, if you see here, normally without inoculation, it will look something like this. It will be clear. And on that, you will swab the organism that you have grown from the sample. Okay, suppose I've got a blood sample and the blood sample has flagged positive. And from there, I've made a gram stain, and the gram stain shows me that it is a gram positive organism. So once I have grown it on a media, I will take those colonies and I will swab it on the Muller-Hinton agar. Once I swab it, I will be putting antibiotic discs on it and then incubate it for 18 to 24 hours at 37 degrees centigrade and take the reading the next day. So when you take out your plate the next day, it looks something like this. This turbid region that you're seeing is the organism which has grown. These are the antibiotic discs, and it shows a zone around the antimicrobial disc, something like this. Okay, so this is the bacterial growth. This is the zone around the antibiotic. Now, this can be measured, and we can find out whether the measurement is falls in the sensitive zone or it falls in the resistant zone, right? So this is briefly how the disk diffusion methods are done. These are done across all laboratories, even laboratories which practice broad dilution. They also have disk diffusion methods because many antibiotics do not come in broth micro dilution, and it is a simpler method, it is a faster method, it is easier to do. The problem with this method can happen is that there are a lot of technical factors which will help you decide whether the antibiotic is giving the correct zone or not. For example, if your pH changes, then the zone of antibiotics will change. If there is any contamination, you may get a wrong antibiotic zone, but that is possible even with broth microdilution. Also, if there is a change in temperature or the duration in which you are incubating the plates, there is a huge chance that your antibiotics may give you a false reading. Okay, so this is the simplest method. This is practiced everywhere in a good laboratory which is accredited. This is a comparable method to any other method which is done. That is your broth dilution. So how do we interpret this? Now, many people ask us like, okay, we know that zones are made, but is any zone sensitive and no zone resistant? So it's not like that. Our Bible is CLSI M100, which is used for all antibiotic susceptibility testing. It gives you charts like these, which tell you if an organism is susceptible, what should be the millimeter zone of each of these discs, and if an organism is intermediate, what should be the zone, and if an organism is resistant to a particular antibiotic, below what zone should the diameter of the zones fall. So this is how interpretation of disk diffusion is done. These are known as breakpoints of disk diffusion, which are given in the CLSI document. This is universally followed across most countries. In certain countries, UCAS guidelines are also followed, but most of them are comparable as far as many drugs go. There are a few drugs where different practices are followed by both of these regulating authorities. So this is a simple way of interpretation of disk diffusion method. Coming to the second method, that is a broth dilution. Now, if you see this image itself, it scares you because it is kind of complicated, right? So either you could take many, many tubes in which you will have different concentrations of antibiotics which are there. So if you see over here, this we have written C1 and C2 are your controls, and all the others are your concentration of antibiotics. So the two tube contains 2 microgram per ml or 2 milligram per liter, any of the notations that you want to use. It contains 2 microgram per ml of antibiotic. This next tube contains 4 microgram per ml. And by the time you come here, the concentration of antibiotics has increased. Okay, so this is a broth which contains the antibiotics. And to that, we will add a broth which contains bacteria, right? So by the time the bacteria is being challenged by different concentrations of antibiotics. Okay, so what do we want to see over here? We want to see the concentration at which the antibiotic wins the battle against the bacteria and stops it from growing. So wherever, now generally how do we detect growth in a liquid medium? It is by seeing whether the media has become turbid or not. So wherever the turbidity reduces, it is that point where you will have the MIC. That is, you will find out that, okay, at this point, the bacteria has stopped growing. So at this concentration, the antibiotic is effective. Okay. So now this entire process is kind of complicated. We can see from this also the challenges of using so many tubes for one antibiotic becomes very, very distressing, and it's very cumbersome for a routine laboratory to do these methods. Right. So generally, MICs were reserved for certain antibiotic testing, but now with the advent of automated broad dilution method, every lab has been able to practice this easily. So this is our Vitec compact machine. The Vitec compact machine also helps in broad dilution. This is the cassette into which antibiotics are already preloaded by the manufacturer. What we have to do, we just have to add the broth with the bacteria, and we will get a reading from the machine which gives us the MIC of the various antibiotics which are present in the panel. Okay, so this simplifies, and that is why you can see many reports which are reporting MICs nowadays, because not only Vitec, there are many automated machines like Microscan, Walkaway, or BD systems which help us with MIC determination. Right. So this is a very important juncture to understand what MICs are. MICs stand for minimum inhibitory concentration. So minimum inhibitory, let's see the technical definition. The technical definition says that MICs are the lowest concentration that will inhibit the visible growth of a microorganism after overnight incubation. So if you see this picture, let us assume that wherever the tubes are dark blue in color or blue in color, there is bacterial growth. So from the first tube till the last tube, we have increasing concentration of antibiotics. So first one has 1 microgram per ml. That is why you're seeing a dark blue color, which indicates a highly turbid broth. And the second one, or the third one, fourth one, you see the turbidity is increasing. At the fifth, between the fifth and sixth, the turbidity disappears and the broth becomes clear. So the MIC, like we know above what it's written, that it's the lowest concentration of antimicrobial that will inhibit the visible growth of a microorganism. So this is your lowest concentration, because beyond that it becomes a higher concentration. So this is the lowest concentration at which the bacteria is inhibited. So this is your MIC. Now we know that the MIC is 6. Then we will compare it with the breakpoints and see if it falls in a sensitive zone or a resistant zone. I will come to those concepts shortly. But it's very important to understand that MIC will be the lowest concentration of an antimicrobial that will inhibit the visible growth of an organism after overnight incubation. We will keep dealing with the concept of MICs frequently in your practice and roundings as clinical pharmacists, and you will be taught much in detail, I'm sure, in your courses, but it's worthwhile refreshing these concepts again and again. Right. So again, we get a frequent question from many practicing physicians. How do we make out whether our report is based on distribution or is it based on MIC? All right. So generally, a good lab will write in its report the methodology that it has used. So if it's written Kirby-Bird distribution method, or it's simply written distribution method, then it means that it has used a distribution methodology. Okay, so if you see this report on your left hand side, you can see that drugs are written and the interpretation is written, whether it is resistant or sensitive, RS. So these are written. Okay, in brackets they have written the strength of the antibiotic discs used. We will choose to ignore this because most of our clinical reports do not have this. They just tell you whether it is R or S if it's done by disc diffusion. However, if your reports have been done by broth microdilution, then you will have the MIC. So this is a report which has been generated from the Vitec machine. 2 organisms have grown, and all the MICs of each antibiotic is mentioned against the antibiotic. The interpretation will be mentioned against the MIC that is written. So ampicillin with an MIC of more than 32 is resistant, and cefepime with an MIC of more than 64 is resistant, and levofloxacin with an MIC of 1 is called as sensitive over here. Okay, MICs between the antibiotics are not comparable. If you want to compare the antibiotic with breakpoints, you have to compare the same antibiotic. So this is how you can differentiate whether your report is done by broad dilution or report has been done by disk diffusion. So this is important when you want to find out the MIC of certain antibiotics. Okay, another important thing that people ask me, so which of these reports is superior, right? Is it a disk diffusion which should be practiced, or is it an MIC report which should be practiced? So generally both of them are comparable. In clinical situations like infective endocarditis, colistin therapy, or in any other cases where vancomycin therapy requires the MIC, MIC based methods are preferred. Otherwise, in a good laboratory which is accredited with standardized procedures, then both disk diffusion or MIC can be a replacement of each other. So there are clinical situations where we would prefer MIC values which are limited, 4 or 5, but otherwise a performed disk diffusion test can give you as much clinical information as a broth microdilution based MIC test. So this has to be there in the back of our mind. Okay, so having dealt with the dry part of the subject, where we actually deal with the nitty gritties of generating a AST report, let us come to the part where we are discussing the interpretation of AST reports. So till now we have shown you reports which have S and R written on them. We also have to understand what these mean. So CLSI tells us definitions of what susceptible or sensitive isolates are and what resistant isolates are. By susceptible or sensitive isolates, we mean isolates which have results within the susceptible category. And once they are in the susceptible category, they are predicted to be associated with a high chance of treatment success when the patient is given that antimicrobial. So anything which is sensitive, whatever antibiotic you give, the treatment success rate is very high. On the other hand, if you have a resistant antibiotic, then it means that the chance, if you treat with that antibiotic, the chance of treatment success will be very low. Okay, so generally people, treating physicians do not prescribe resistant antibiotics unless and until it is a pan drug resistant stage and resistant strain, and they need various combination of antibiotics to come to a situation where the patient can be treated. Okay. So other than that, what is intermediate? It is also important to understand that in what situations antibiotics which are intermediate can be used for treatment. So intermediate zones are somewhere between susceptible and resistant. Technically, if you see, the intermediate zone helps you in reducing the error of your reporting. That is, if resistant strains can, are if there is some problem in your technical performance of the test, sometimes resistant strains may appear intermediate. If there was no intermediate zone, they would appear susceptible, and that would cause a mismanagement of the patient. So you have an intermediate zone which buffers out any error which is caused because of technical errors in the reporting. Also, the intermediate zone speaks about increasing the dose of antibiotics. Okay, so CLSI has included intermediate category for many reasons. The most important being that in certain situations you may increase the dose of these intermediate antibiotics, and that will improve the chance of treatment success. And also at certain anatomical sites, the antimicrobials can get more concentrated. At these sites, an intermediate result of the antibiotic can prompt you to treat that infection with an intermediate antibiotic. For example, a lot of drugs get excreted by the renal system. So if you have a urinary tract infection and you have pan-resistant antibiotic with a few intermediate antibiotics, you can always try treating with the intermediate antibiotic, because the urinary concentration of those antibiotics will be much higher. And if the infection is in the urinary tract, it will get treated. So generally, we do try this with urinary tract infections, but you're always advised to avoid using intermediate antibiotics in things like sepsis, which are very life-threatening and where the concentration of antibiotics that you are seeing on your plate will correlate with the concentration which is there in the bloodstream. Okay, so these are some of the reasons why intermediate category is important, and the kind of drug resistance we are seeing in the community nowadays, we need to understand intermediate so that we can repurpose many intermediate drugs for treatment purposes, because sometimes patients do not have any drugs to fall back on the level of pan drug resistance or multi drug resistance that you are seeing with your routine infections that are coming into the hospital. Right. So, coming to some of the practical challenges of interpreting the antibiotic susceptibility tests. Now, very often we are asked, should we be testing all antibiotics? Should do we test all the antibiotics? Is it that if certain antibiotics are not reported on an AST score, uh, would they have tested everything, and would it be possible for the team to just report some of these? So as far as testing all antibiotics goes, it is also important, in case we do not test, is it that we decide which antibiotics to put for some organism? So what is the philosophy, or what is the science behind deciding what antibiotics to test for what samples and what patient groups? Okay, so the answer for do we test all antibiotics for all samples is no. We neither have the resources, neither we have that much flexibility that we can test outside a research laboratory for all the antibiotics that are available for all samples. So generally there are panels which have been made. So if you see over here, this is a panel made for all the Enterobacteriaceae. So we will have a list of many antibiotics which we would put if we get something like E. coli from urine. We have a list of antibiotics which we would put if we get E. coli from blood. And we have a list of antibiotics that we put from pus or any other samples. So these are how panels are made. And these panels have been provided to us by the CLSI guidelines. The CLSI guidelines have shown that success of treatment for urinary isolates with the following antibiotics is much higher as compared to success with treatment with some other drugs. So that is the basis of deciding what antibiotics to test for what samples. So we have to understand that there is a drug bug reporting panel which is available for many of these samples, right? So many of these. So like even Vitek has different panels. It tells you that these group of antibiotics will be tested for Staphylococcus species. If you see the certain antibiotics be suppressed, which will be tested for Enterococcus, right? Similarly, for gram-negative organisms which come for blood, we test a particular set of antibiotics. For urine, we test a different set of antibiotics. So this is broadly to understand that all the antibiotics will never be tested. It will only be certain antibiotics which are tested. Having said that, many a times you can use one antibiotic to interpret the other antibiotics report. For example, in this group, if we are testing imipenem and meropenem, we can also interpret what the susceptibility of other carbapenems may be like. But also, if you are testing certain other drugs, you can interpret, like colistin, you can interpret, okay, polymyxin sensitivity will be similar to colistin sensitivity. So these are certain rules which will help you in understanding why limited number of antibiotics are tested for organisms. Okay, so only in certain laboratories you may have the luxury, or certain research laboratories you may have the luxury to test for all the antibiotics. Otherwise, group representative antibiotics are taken, and antibiotics which are usually used in the clinical practice for particular organisms are taken, and they are tested for these AST panels. Right. So another important thing, do we report all antibiotics? Sometimes we hide certain antibiotics. Microbiologists have this habit of hiding a lot of things. Okay, so for a long time, and even CLSI tells that it would be wise if you would report if in case an organism is pan sensitive, in those cases, it would be advisable to report antibiotics which are generally the first line antibiotics. If you have any resistant organism in the first line, then you should go with the second line options. And then if you have all the resistant organisms, then you should go for the third line organisms. Okay. So this is the cascade reporting. CLSI does tell us which are the antibiotics that you should release in case of pan sensitive, because we want the doctors to use that antibiotic for treatment. Okay, unless and until it's a complicated case, generally the physicians would treat with base. Like if you have beta lactams, you would use with baseline beta lactams. But if you generally these are not. I mean, even if these are sensitive, sometimes people do use third generation cephalosporins or carbapenems. So in order to stop this practice, generally it is advised that you do a cascade reporting where you release the first line antibiotics first, and then the second line, and then the third line. Okay, this is while it is advised, it is not very practical to practice, because sometimes we do not know what is happening with the patient. We do not know the kind of allergies he has. We do not know what is the reason that he might be in a life threatening situation, and you might have to go for a third line antibiotic directly. So understanding those is very important, as and these are the reasons why there is always a tussle between the clinical side and the microbiology lab if you practice cascade reporting. So as far as based on the cascade reporting itself, the WHO has come up with an aware classification of antibiotic reporting. Okay, so we have a broad group of access. So if you see, this is a pyramid, and the broad group of access antibiotics is there, which is always the first or the second choice for common infectious syndrome. Then you have a watch group. Watch group is also a bigger group of antibiotics which can be used in case your access group is resistant. And then you have a last resort option against MDROs, which is your reserve group of antibiotics. So WHO has classified antibiotics on the basis of the it is again a hierarchy of first tier, second tier, and third tier antibiotics. Access and watch group are the ones which are generally available. Reserve group, you need to have certain policies in place in your hospital, which will ensure that reserve group is being tracked, and the antibiotic stewardship team does an surveillance to ensure that the reserve groups are only are prescribed after consultations with the antibiotic stewardship committee. Okay, so this is a broad outline of all these drugs and how WHO aware group does. So where does this fit into our AST reporting? So most of the laboratories have tried to incorporate the aware classification of antibiotics in their reporting system. So they suppress the reserve drugs and they put access and watch group. But very often tertiary care centers, the patients have come in with MDR bacteria, or they come in with XDR bacteria. In those cases, reserve antibiotics have to be released. So the ones in which we do not release the reserve antibiotics, also very often we have to convey the message to the clinicians. So somewhere we have to strike a balance between suppressing reporting and in bringing about a behavior change in prescription practices, because just suppressing the antibiotics is not helping us much in achieving the goal of preventing the misuse of antibiotics. Right. So let us go through some case scenarios, and these case scenarios have been developed to make you understand certain concepts which of antibiotic report, the antibiotic susceptibility report interpretation, which will help you in your day-to-day practices. Okay, so this first case is of a patient with fever of 3-day duration who presents to the medicine OPD. After a thorough examination, the physician orders investigations which include blood and urine culture. Reports are anticipated to arrive within 48 to 72 hours. So like you know, all your culture reports, your AST reports take 48 to 72 hours. So the question is, how should you approach antibiotic commencement in this patient when you do not have an AST report? Okay, this is a frequent scenario. This is frequently clinicians call you up, the clinical pharmacists who are rounding call us up and ask us how to go about this in the absence of any AST report. Okay, this is a common situation where we see in our daily practice. Okay, so to understand what is the correct way to approach such cases, we have to have the basic concept of broad spectrum antibiotics and narrow spectrum antibiotics. Okay, so broad spectrum antibiotics, this is a chart which is available on Wikipedia itself, and I saw this as a backdrop in one of our clinical pharmacists' desktop, and it is a very exciting and interesting way to see how antibiotics behave. Okay, so if you see certain antibiotics, they will act on both gram positive as well as gram negative bacteria. These are your broad spectrum antibiotics. Okay, so if you see certain bacteria like vancomycin, they will act only on gram positive organisms, and certain bacteria may act only on aerobic organisms. Certain bacteria will have also anaerobic effect. So broad spectrum antibiotics cover various spectrums. They cover the gram positives, the gram negatives, the anaerobes, the atypicals. So a true broad spectrum antibiotic may not cover all the classes of bacteria, but it covers more than one class. Narrow spectrum, on the other hand, will cover only a few classes of organisms. For example, vancomycin. Okay, for example, your clindamycin may act against a particular 2 or 3 group of organisms. It has no effect on your gram negative organisms. So this is how we tailor our treatment when we don't have an AST report. We should always start with a broad spectrum antibiotic, and then when your antibiotic susceptibility test report becomes available, you should narrow it down to a narrow spectrum, or based on your susceptibility report, you should target the organism, deciding what is the best antibiotic which is working against it. Okay, so always change your antibiotic after you receive your AST. It is always nice to start with a higher antibiotic depending upon the kind of infection you're dealing with, and then step down to a lower level narrow spectrum antibiotic. So this is the basic point of stewardship that is always said, that start with a broad spectrum and then narrow down to the narrow spectrum antibiotic. So another important case scenario where we will discuss the concept of another new concept, or a concept which is well spoken about. So when you're on your antibiotic stewardship round, the junior doctor shows you the following report and complains that the microbiology lab has not reported ceftriaxone for this patient. So what do you think of this? Right. So we also get this question frequently asked. We have a Staph aureus isolate, and in the Staph aureus isolate, the patient is already on ceftriaxone and you have not reported ceftriaxone. Okay, so if you see this report, we have reported penicillin, which is resistant. We have reported oxacillin, which is resistant, and we have reported many drugs. Second line, first line, restricted, everything we have reported, but we have not reported the third generation cephalosporins, which are the workhorse of any hospital. Okay, so why didn't we report it for Staph aureus? Is because ceftriaxone sensitivity can be interpreted using oxacillin or cefoxitin sensitivity. Okay, so in Staph aureus, we have a very important concept which is known as MRSA. So these drugs like cefoxitin can be used as surrogate markers for methicillin or oxacillin resistant, and all MRSA will be resistant to all beta-lactam antibiotics except certain ones like ceftaroline and ceftobiprole. So that is an important thing that we should remember when interpreting AST reports, that not everything will be expressed. So generally, we put a comment at the bottom of the report when we isolate MRSA that all the beta-lactams, beta-lactam inhibitor combinations will not work in these patients. So that is what we should know, and we should not go looking for particular antibiotics. We should know about the group of antibiotics that we are dealing with over here and try to infer the results from them. So these are international standard practices where cefoxitin and oxacillin tell you whether cephalosporins, penicillins, amoxiclav, ampicillin, none of these will work in MRSA. So that you should be aware of, that cefoxitin or oxacillin are surrogate markers for methicillin resistant staph aureus. Similarly, in Salmonella typhi, if we find nalidixic acid resistance, we can infer that fluoroquinolones might not be very successful in treating these infections. Okay, so now we have various other markers like p-floxacin and other things which detect this, but these are certain surrogate markers which tell you whether any other antibiotic will work or not in these patients. Now, coming to a third very important concept. If you have a report where everything is sensitive, what antibiotic should you choose? Okay, many other factors will go into choosing an antibiotic, but when we have a pan sensitive um, pan sensitive report, it is very important to see the MIC. Okay, the MIC, like I said, is the lowest concentration of an antibiotic that inhibits the growth of the given strain of bacteria. Your MIC cannot be compared to the MIC number of another antibiotic. And your choice of antibiotic again should depend upon many things other than MIC. The site of infection, the antibiotic's breakpoint, safety, ease of use, and cost. So these are many factors, but still after that, you may have 10 antibiotics in a report which are sensitive. How do you decide which may be the best for this patient once you have considered all the other factors like breakpoints or site of infections or uh, any antibiotic breakpoint, safety, the cost of determining the optimum antibiotic? These, when you have considered, then what to do? Right. So there is a very important concept, that is the breakpoint to MIC quotient. So in this, if you see, the breakpoint is the point at which the antibiotics, it can be told, see, if you see over here for ceftazidime, the breakpoint is somewhere around 8. Okay, anything which is less than 8 is sensitive, and anything which is more than 8 is either intermediate or resistant. Okay, so BMQ is the breakpoint to MIC quotient. So if you see over here, whatever we have rounded up, that is your MIC for that particular organism. The farther away it is from your breakpoint, if you see over here, the farther away it's from the breakpoint, the more chance that this drug will lead to a successful therapy. So it is very important to measure the BMQ ratio. It is kind of a taxing process to do this manually. There are lots of softwares which do it automatically, but you should remember that BMQ or the breakpoint to MIC quotient can guide you in choosing antibiotics when many of them are sensitive. Okay, so this is a Pseudomonas aeruginosa isolate, and if you see, ceftazidime would be your, one of the common things that we talk about to be given. But if you were to see the BMQ over here, we see that amikacin is having a very good BMQ over here. The breakpoint to MIC concentration is almost 16. Like if you see 16 to 1, and here if you see, this is 16 divided by 8, that would be 2. So that would be a much lower BMQ as compared to your amikacin. So if it's urinary isolate of Pseudomonas aeruginosa, then you can go ahead and use amikacin in this case. Okay, but several other factors will go, but this is how you use the BMQ tables. So another important concept that we discussed through this case is the concept of intrinsic resistance. So you have a 40-year-old male with suspected meningitis case, and he started on injection ceftriaxone. His CSF culture report turned positive after 48 hours with the organism identified as Listeria monocytogenes, which is sensitive to ampicillin, gentamicin, ciprofloxacin, and cotrimoxazole. Should you change the ceftriaxone therapy in this case? So this is again a very important concept. What is intrinsic resistance? Listeria generally is intrinsically resistant to ceftriaxone. And in this case, you will have to change the therapy to ampicillin plus gentamicin. So when we deal with bacteria, there is every group of bacteria has certain drugs it is intrinsically resistant to. So again, an important question, do we need to know about all this? Actually, your AST report can help you that way. Usually, good reports tend to have a comment on what are the intrinsic resistant drugs for a particular group of bacteria. So, a good AST report will guide the treating physician that these drugs are intrinsically resistant. So please do not use them. Okay, so for Burkholderia, your colistin is intrinsically resistant, or for any other drugs, there is a long list. Azithromycin is intrinsically resistant in E. coli. So these can be, you don't need to remember all this, but your AST report should be giving you, or it is advisable that AST reports tell you that these group of bugs are resistant, intrinsically resistant to this particular antibiotic. Right. So just to wrap this up, let me tell you some of the things that we discussed in this webinar is about your antibiotic susceptibility testing. Antibiotic susceptibility testing is one of the most clinically useful diagnostic tests, which is done in the clinical microbiology laboratory. We do many methods. Disk diffusion and broad dilution are the most predominant methods. Disk diffusion is easy, but certain clinical conditions require you to report the MIC. And when we choose an antibiotic based on our AST reports and we interpret our AST reports, it is important to understand that merely on the basis of an AST report, we might not make a good choice. It is important to see the site of infection, to see intrinsic resistance, to see BMQs, toxicity, allergies, etc. There are many other things which come along with interpreting these reports, or your daily rounds will throw up cases of intrinsic resistance or surrogate markers. Discussion with the clinical microbiology lab will always help you in deciding what antibiotics may work for a particular case. Thank you so much.
Thank you so much, Sabia ma'am. You have discussed the AST reporting in a very comprehensive manner. You used a lot of useful case scenarios. I really appreciate your effort in taking this session. And I would like to comment that your session was really insightful, because even I have thought which is superior with this, whether MIC reporting or this disk diffusion, which is superior. I think it's still like kind of controversial thing.
No, actually, the thing is, if it's a lab which has done both of this diffusion as well as MIC in a proper way, both are comparable. But yes, if you have a case of infective endocarditis, if your patient is undergoing a combination therapy with colistin, if you have a case of meningitis in which vancomycin is being given, in those cases, MIC is far superior to disk diffusion. You need to do it for your patient. But otherwise, if the test is well done, both of them are comparable. There is no reason that you should, sometimes small laboratories do not have the budget to buy expensive equipment and do MICs. So it would not be right on your part to insist that every laboratory shifts to the MIC system. And sometimes we see there is breakdown of supply chain, especially in COVID. So in those situations, you should have a backup method of disk diffusion because it helps you out in these situations remarkably well. So it has stood the test of time, and the only idea is that laboratories should standardize their processes and they should always participate in a quality control program with a standard organization so that their results are comparable. That is the only reason which only in certain methodologies, MICs do have an important role to play.
Yeah, I think this word has to be spread everywhere. It's lacking in our clinical scenario very much, and especially with the cascade reporting system.
Yes.
Incomplete filling of this culture acquisition form. Actually, open communication is very much needed in this antimicrobial stewardship field. Without that communication with clinical microbiology department, nothing works as perfect.
No, I think there's always, it has to be a two-way road where the communication goes equally promptly from the laboratory and is given also to the laboratory. So both the teams have to participate actively. It shouldn't be that we also report something and just sit down and, it's okay, we have reported it, now let them decide what has to be done. So it has to be a two-way channel where the clinical team and the laboratory team communicate and come up with the best strategy for the patient. And even the clinical stewardship teams are very important in this because they can be that link between the laboratory and the practicing physicians.
Okay, very insightful, ma'am. Thank you, ma'am. Thank you once again for taking this wonderful session for us. And to all the viewers watching, thanks for joining. Thanks for attending this session. The FCPA's RD Forum is all prepared to assist you in learning about clinical microbiology and infectious disease. And thanks once again. Thank you. So let me wind up. See you in the next section with another useful topic. Thank you.
Thank you very much.